You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello, everyone. I'm Patti Tripathi, your host for Breathe Easy. Good sleep is part of an international recommendation for good heart health. Joining us are two researchers from Europe, Dr. Zhu and Dr. Kobayashi Frisk. I hope I pronounced that correctly. Tell us more about the study, which involved 3,800 middle-aged adults, you said, and they went to some extensive health examinations, including blood pressure measurements and overnight home study. You divided them into 4 groups. Tell us about how you divided them and why you wanted to do this study in the first place.
Yeah, so basically we wanted to look at the impact of having multiple sleep disorders, notably the two most common sleep disorders, which are sleep apnea and insomnia, and their combination on the risk of having uncontrolled hypertension. And we were able to look at this at a population level because we had data from something called the SCOPY study, the Swedish Cardiopulmonary Bioimage Study. And it looked at data from middle-aged people in the population, and studied their health in a very broad manner. And what we looked at was their sleep recording to look at if they had sleep apnea or not. And also they answered a questionnaire that we used to diagnose or at least indicate if they had insomnia. And then their blood pressure was also measured. And then we were also able to ask them if they were on any kind of blood pressure treatment as well. So when we looked at different categories of high blood pressure, you have people with uncontrolled hypertension that have a blood pressure over, 140 over 90 mmHg. And then you also have people that have a blood pressure under that level, but are taking blood pressure medication, which is controlled hypertension. And then you have the people who have an ideal blood pressure and are not taking any medication.
And the consequences in this study, you found that people have stress, kidney disease, possibly obesity, and other risk factors.
Yeah, we looked at other factors to try to control for them to see if it was actually the people that it was these diseases that was associated with the hypertension and not something else that they might also have, like, for example, obesity. And if you factor all those other risk factors out, we still saw that there was a relationship between hypertension and the combined insomnia and obstructive sleep apnea, or COMISA.
You had, this is a community-wide study of almost 4,000 people, and you divided them in 4 groups. How were they divided?
Yeah, I can take that. So we looked at people with different types of sleep health categories, one can say. So we looked at people who had sleep apnea, or those who had insomnia, or those who had both of them, versus the healthy group that didn't have either of the disorders.
And what were your findings after studying these groups of people? New information than compared to other studies done in the past?
Mm-hmm. So we looked at the relationship between having these sleep disorders and the relationship with uncontrolled hypertension, which we, as far as we know, are the first study that looked at that in a population level. And what we found was that both sleep apnea alone, as well as sleep apnea with insomnia, was associated with an increased risk of uncontrolled hypertension. And the risk was higher among the participants that had both sleep apnea and insomnia.
So is this study also apply to American patients, American population?
I mean, we would think so, but we looked at a population that was based on the population that lives in Gothenburg, Sweden. It's the second largest city in Sweden. And I would assume that we would be able to extrapolate that information to other populations as well.
And so what do you recommend? Monitoring for these, the people who have insomnia and apnea, greater marking, what are the solutions?
So, since this was a cross-sectional study, we can't say that sleep apnea or insomnia causes hypertension based off of our study. But what we can say is that maybe it's worth monitoring people with these disorders to see if maybe they have the other disorder as well, and to kind of treat their problems from both sides, from both the insomnia and the sleep apnea side, and also to keep an eye on their cardiovascular health.
Dr. Zhou, let me ask you, you also mentioned cognitive therapy. When is that recommended?
It's like this. First, we need to consider whether this patient has both conditions or has only one of them. If they happen to have insomnia, and usually the first-time treatment is cognitive behavior therapy, and it includes several type of session and trying to really using behavior therapy and to really help the patient to improve their sleep for insomnia. And for sleep apnea, we mainly recommend positive airway pressure treatment, which is considered the gold standard for our sleep apnea treatment. And
what is that? What kind of treatment?
Yes. Okay. So let's take one step back, because sleep apnea is a pretty common condition among the general population. It is estimated, at least in Europe, approximately 18% of adult population, they have some type of sleep disorder breathing. And the reason for this is mainly due to sleep, because when we are awake, we are alert, and there's a very strong wake stimulus, maintain our upper airway open. The patency is there, muscle activated, and we can talk. So you never see an apnea during wakefulness. But when you go to sleep, your muscle tend to relax. And due to the position, you're laying supine, usually most of the time, the gravity also cause your upper tend to collapse. Based on this condition, some of the patients, they have a tendency to collapse their upper airway during sleep. It can be complete collapse, we call apnea, or it can be partially collapse, we call hypopnea. So either way can cause we call intermittent hypoxia, because just hold your breath, after a couple seconds, you will see your oxygen level go down, right? So if you explore to this condition multiple times during your sleep, you have a condition that you intermittently expose yourself to a hypoxic condition, which is not good. And the second issue of this behavior is that due to intermittent hypoxia, you wake up in the middle of sleep, you cause arousal during sleep, disturb your sleep structure. And if you expose this condition multiple times, and you lose also your sleep in the middle of the night, and this can can cause several consequences. You just mentioned cardiovascular disease. Actually, there are also evidence suggests it's associated with metabolic disorder, including type 2 diabetes, hyperlipidemia, and also actual other things.
Obesity.
Obesity, yes, that will be a vicious circle, because obesity can cause sleep apnea, and as a vicious circle, sleep apnea can cause daytime dysfunction. And if you have daytime dysfunction, like sleepiness, you tend to be more sedentary, and then it will be more have a vicious circle, cause you have more lower expenditure during your daytime, you do less activity, and then make your obesity even worse, right? So this is going to be a vicious circle, I would say.
And you recommend sleep studies?
Yes, absolutely. This is something we really learn from our observation. What we see here is that no, we can of course ask patients whether you snore, whether you have no breathing pulse, no during the night witnessed by your bed partner. However, this is only symptom related. The real truth has to be estimated by the objective assessment, including sophisticated sleep study or ambulatory home sleep apnea testing.
And this involves masks.
And that's mainly for the treatment. For the diagnostic, we are trying to analyze their signal, including mainly for the nasal flow signal, because that's the evidence to show whether you stop your breathing or you have an upper flow limitation. Partial collapse causes flow limitation. So we would like to have nasal flow. We also would like to have more information, for instance, oximetry, finger pulse oximetry to assess your oxygenation during the night to see whether your event is associated with intermittent hypoxia. Ideally, we also would like to have some EEG measure your brain wave. Then we can measure your sleep status, which means that we can see whether you really wake up in the middle of your sleep or you just sleep throughout the night. So that would be ideal. However, as long as you have nasal flow and sufficient measure of oxygenation, we can call this home sleep apnea testing according to American Academy of Sleep Medicine. This is sufficient to diagnose sleep apnea patients.
And there are a lot of new technologies, new procedures that I'm reading about. Have you seen that?
Yes, I do, because I've been working with this type of disorder for almost like 25 years. And we see a lot of changes. No, we are lucky in a way because we have so many options in 2026 now compared with 20 years ago, even 30 years ago, we have a very limited solution. And by that time, the main reason to treat is using the positive airway pressure, which we call this is provide a consistent airway pressure to your upper airway, and then it's almost behave like up the air splint. Open your airway. So no matter what causes sleep apnea, they open your airway. As long as you have central respiratory drive, you can breathe normally, and your disease cured by that night. Then, however, you have to use every night. It's going to be a chronic condition. You need to use every night to remove the disease, and it's very.
They're no longer the big elephant tusk-looking one. They're portable ones too now.
Yes, but still, you need a decent machine provide with your airway. So, during the past 25 years, the technology advancement gave us a chance. From very heavy device, we can have a small positive airway pressure device, as light as like 1.51 kilo, if you want. However, you still need a tube, you still need a mask. So that require a long-term commitment to the treatment adherence. So this is a major challenge for our field to keep the patient in the treatment plan. And nowadays, we have more options. This is great news. The second recommended treatment is called the mandibular advancement device, which use the oral device move your jaw forward. But mechanically they can open your upper airway. This is also recommended by the AASM. However, this is 2026. In 2024, for the first time, FDA approved the first drug in its kind to treat obesity sleep apnea patients. This is called tirzepatide. It was approved before Christmas 2024.
And I've seen like nose clips too.
Yes, there are other alternatives now which can be used to treat sleep apnea. But we are talking about patients in general. And that type of treatment may help to certain part of patients, but may not apply to a very general, broad perspective. For instance, if you have a very severe disease, the first line treatment is always going to be the positive airway pressure treatment. Of course, we have more solutions like surgery, and also we have more solutions like even FDA approved mouth apnea treatment. You can do daytime muscle training, but that is only applied to selected group. So we are talking about multiple treatment modality, but we have to do precision medicine, individualize it with patients, clinical symptom, endotypic traits, and then prescribe them with their treatment which suit them the best.
Okay. Other than the health problems, psychiatric problems, your study also found economic implications due to sleep problems.
Yes, actually, there are several studies address this. So sleep apnea can cause a lot of consequences, not only cardiovascular metabolic disease, but also is linked to dementia, cognitive impairment, increased traffic risk, and reduce work productivity. And we also discuss other type of mood disorder due to sleep apnea. So it's associated with multiple consequences. It indeed can cause the burden for the society. And that is why we call this is a burning question. We need to identify in a timing fashion and give the treatment in the timing fashion.
Has a similar study been done in the US? Have you been talking to other scientists?
Yes. The insomnia and combined with obstructive sleep apnea, actually, the first case described was in 1973 from Stanford. That is the first time sleep apnea, called as a disease. But at that point, that patient has very severe insomnia symptoms together with sleep apnea. But at that time, they called them sleep apnea. Later on, there are several studies address the combined situation, but they never considered this two separate disease, but they thought this is caused by sleep apnea. But actually, there are some patients, it's indeed not the case. There is a comorbid condition. So even though you remove sleep apnea from these patients, they can still have residual insomnia symptoms. So we need to treat them as a combination. We never underestimate the burden of the double disease of these patients.
Okay. So recapping, you are recommending there's international recommendation to protect heart health, and you're finding that people with multiple sleep disorders have high blood pressure, and there are economic burdens. What other, and there are so many other treatment plans which you have to discuss with your provider, correct? And perhaps sleep study or other technology to help. What would you like to add? Anything else?
Well, I would say that if you have a patient, just like Mio just mentioned, if you identify them, they have both type of symptom or burden, insomnia disorder and sleep apnea. And the first thing you need to think about, okay, we need to treat both. And the second thing you need to also think about that due to this type of complex situation, if you treat one of them, the other disease may cause problem for them. For instance, we found their studies suggest if you have insomnia with sleep apnea, these people tend to have a low CPAP compliance because they wake up in the middle of the night, they don't want to use mask any longer. And then you reduce treatment efficacy. So the ideal scenario is to combine this cognitive behavioral therapy with the positive airway pressure treatment. And usually this can be a synergetic treatment effect together.
What is something else interesting about the study that you found?
Yeah, we also looked at a potential, we look for a potential mediator or a factor that could be mediating the relationship between the sleep disorder status and the hypertension status. And what we found was that hypoxic exposure, or more time spent with a lower oxygen saturation, may have been a mediating factor that could be causing this sort of effect.
Okay. Dr. Zhu and Dr. Kobayashi Frisk, I hope I pronounced that correctly again. And anything else that you'd like to add?
I just want to mention that sleep apnea is underestimated in the general population. What we found here is that only approximately 10 to 20%, or maybe 20% more correctly, of sleep apnea patients really diagnosed and treated in our clinic, and the rest of 80, and they are there, but we never got enough resource, and we don't have enough awareness to find them and treat them in a timely fashion. What we see here, this is a well-established cardiovascular risk factor, has been shown a very strong association between uncontrolled hypertension, like our studies demonstrated, or has been shown that sleep apnea is established risk factor for atrial fibrillation. And with this in mind, I think we need to understand that we need to active to, in the primary care setting, in the family medicine, and any obesity clinic, any clinic with their chance, try to ask their sleep symptom, whether they snore, whether they have other type of daytime symptoms which have some suspicion of sleep apnea, and send them to further diagnose test. And on the other hand, we also need to ask their insomnia symptom to identify whether they have a good sleep quality in their daily life, to understand whether this can be another burden, the sleep disorder for these patients. And with this in mind, I would like to thank you for your interest for our study.
Ideally, how much sleep do you want people to get? 7 to 9 hours for adults?
Well, it depends. And according to the American Academy of Sleep Medicine, the optimal sleep duration is 8 hours. The adequate sleep duration is 7 hours. So in our study, we have a criteria that you need to show at least 4 hours of good nighttime recording in order to eligible for the analysis. But ideally, we would say that the sleep cycle, at least 6 hours could be sufficient. And also, very importantly, we need to consider that patients go to bed at different time. Okay, so in this case, it is very important to also have some sufficient window, second half of the night, when we tend to have a more REM sleep. Then you may catch some new insights from that special sleep stage. So I would say that 6 to 8 hours of recording time is sufficient to diagnose sleep apnea.
Okay.
The minimum criteria is 4 hours.
If you don't have any big problems, is melatonin okay to take just to fall asleep? That's what a lot of people do.
Yes, absolutely. And I fully agree, because this is an issue not only for the US, but also for Europe. And people think this is the insomnia drug. If there are any problem, they just take it. This is actually, it's not a hypnotic drug. It's a phase drug. It's trying to really synchronize your circadian clock with your sleep. So basically, according to the guideline, melatonin is not good, recommended to treat insomnia. Definitely not sleep apnea.
Okay. Thank you both very much, Dr. Zhu and Dr. Kobayashi Frisk. And we'll see you soon.
Thank you so much.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.